Hello, everyone, and welcome to the Medical Fitness Podcast. I'm Jeff Young, and in this episode, my co host, Dr. Thomas Hammett, and I speak with physician associate and obesity medicine specialist, Karli Burridge. Our podcast is brought to you by the Medicine, Rehab, and Fitness Institute and JY Kinesiology LLC, both of which are dedicated to medical fitness education and building the bridge between medicine, rehab, and fitness. You can learn more at mrfinstitute.org. The purpose of our podcast is to provide you with principle and evidence-based content on all things related to exercise science, strength and conditioning, medical fitness, and building the bridge between medicine, rehab, and fitness. In this episode, Karli presents a broad and interesting insight into her background and what led her to the field of obesity medicine, how she incorporates the four pillars of clinical obesity treatment into her practice, what she recommends in terms of physical activity and exercise, and common misconceptions around obesity and obesity care. Let's get started, and I hope you enjoy the conversation. Hey, everyone, welcome to the next episode of the Medical Fitness Podcast. And before I get into any formal introductions, since there's three of us, the first thing I want to do is say hello to our special guest, Karli Burridge, physician associate. So, hey, Karli, welcome to our show and excited to have you here.
Thanks so much for having me. I'm so excited to spend this time with both of you.
And then also, obviously, I'm excited to have my friend and colleague and co-host, Dr. Thomas Hammett. Thomas, thanks again for joining this one as well.
Yeah, I'm excited to be here.
So with that, the first thing I'm going to do is being a little bit formal here, and I'm going to read off Karli's bio so that we're obviously going to get to know her during the course of this podcast. But I'll start off by reading her bio so you can get some insight as to who she is and what her expertise is in, and then we'll go in from there to the questions. So Karli Burridge is a physician associate, and I know through Sheila Aubois, who introduced us, that there's a transition with the terminology, right? For the longest time, or from the beginning, it was physician assistant, right? And now is transitioning to being a physician associate, which you maybe want to talk about a little bit more in a few minutes. And she's a fellow of the Obesity Medicine Association. She's a co-founder and president of PAs in Obesity Medicine and serves on the board for the Illinois Obesity Society. She's the owner of Gaining Health, where they offer a roadmap, resources, and support for clinicians who want to start an obesity management program. Karli is also the host of the Gaining Health podcast, and she works clinically at Ascension Medical Weight Loss Solutions in Westmont, Illinois. I'm just curious, is that a close suburb of Chicago?
It is. It's a western suburb of Chicago. So, yeah.
For 2 years, from the age of 2 to 4, I actually lived in Glen Ellen. So is it near Glen Ellen?
I live in Glen Ellen. Yes.
Oh, that's great. Yeah, that's
That's
crazy.
crazy.
Yeah, so from the age 2 to 4, I lived in Glen Ellen. How crazy is that? Um, she holds a certificate of advanced education in obesity management, is the recipient of Obesity Medicine Association's Dr. Raymond E. Dietz, if I'm pronouncing that correctly, Meritorious Service Award, the Dr. Vernon B. Asler Award, and the Committee Leadership Award. So as you can see, she's absolutely a subject matter expert, and she has authored several publications and clinical practice statements on obesity care and is passionate about educating clinicians on obesity care and helping clinicians launch compassionate, evidence-based, and successful obesity medicine programs. So again, very excited to have you here, and I'm going to use that to lead into the first easy question, which is, before we get started, could you tell us and our listeners a little bit more about you above and beyond the bio, and also what a day in the life looks like for you right now?
Yeah. So thank you so much for the introduction. And again, for having me here today. This is a topic I love to talk about. And my background is kind of similar to yours. I started out in exercise physiology. So my undergraduate degrees, I ended up getting 2 degrees, one in psychology and one in physiology, because I just really believe in that holistic care and that you really can't treat one without the other. And what fascinated me about exercise physiology so much, and just exercise in general, was that we saw so many benefits on the physical health side, but also on the mental health side. So that's, and I'd always been an athlete. And so just the exercise world was something that has always fascinated me. And so the more I started getting into these studies, the more I was like, wow, we can do so much for people's health and well-being through physical activity. So I went to grad school at UT Austin for clinical exercise physiology, and with the goal of doing kind of, Jeff, similar to what you're doing right now, is creating exercise programs for special populations, for people with chronic health conditions that we know can be, that exercise can be a really important part of their treatment plan, but it's often a part of the treatment plan that's missing, right? And so that was my goal in graduate school. But then we were reading a book by the New York health commissioner at the time, Tom Farley. And in that book, it's called Prescription for a Healthy Nation. And he talked about how, in his opinion, primary care providers were really the ones who needed to lead the charge in terms of disease prevention and in getting at a lot of the root causes of so many of the chronic health conditions that we see these days. And so that kind of triggered me to think about going the medical route. So I thought about going to medical school, and then I learned about, I didn't even know what a PA was at that time. So I learned about what PAs were, and I decided that sounded like a good route for me because I really like working as a team and with teamwork. Again, I've been an athlete my whole life, so I love being on teams and working together with people. So long story short, that's how I kind of ended up in PA school. And you're right about the name transition. So PA stands for physician assistant, or now we're transitioning to that name of physician associate, just because there was a lot of misconceptions around what PAs do. And when I first heard the term physician assistant, I thought it was like a medical assistant or, and so a lot of people, yeah. Right. Because it sounds like you're somebody's assistant, right? And so, but then when I actually learned more about it, I learned that, oh no, PAs actually, yes, you collaborate with a physician. You have somebody at your practice who is a physician who technically you collaborate with, but you see patients for the most part independently. And it depends on what field and what position you have and things like that. But for the most part, you're treating patients independently. So you're seeing new patients, you're assessing, you're providing a treatment plan, you're prescribing, you're ordering and interpreting labs and all those things. So, I thought, okay, the reason why I didn't initially go into the medical field was because I felt like, and this was the early 2000s, what we were seeing is people would go to see a medical provider and they would just get a pill, a prescription, or, just a Band-Aid to cover up whatever illness popped up this time. But they weren't really addressing the root cause of what was causing these medical conditions, nor was lifestyle really being discussed, it seemed to me, at medical appointments. It was more like, just take this pill, take that pill. Yeah, try to eat better and move more. But that was about the extent of the lifestyle counseling. And so I said, okay, well, if I'm going to go this route and I'm going to become a medical provider, I want to do things differently. I want to make sure I really focus on the lifestyle component, talk to my patients about things like nutrition, physical activity, sleep, stress management, and as much as possible, treat medical conditions without medications if I can avoid it. And then if I have to use medications, fine, but always as an adjunct to also talking to them about these lifestyle factors. So that was kind of my goal going into the medical field. And now my goal is kind of not just to change how I approach medicine and how I practice medicine, but really to change the way that the medical field in general operates, and to really not just do it myself, but have this really big kind of a revolution in how medical providers manage chronic conditions. And so I guess long story short, that's sort of where I am today, is helping other clinicians build obesity medicine practices and start obesity medicine programs, because obesity medicine really does focus on those lifestyle pillars, the nutrition, the physical activity, the stress management, the behavioral component. But then also we use tools like pharmacotherapy, medication, or sometimes even bariatric surgery if needed, to treat the patient, because this is a medical condition that for most people, once they have obesity, the lifestyle stuff isn't enough to treat the disease. This has been my passion for many years, and now it's exciting to be able to help other clinicians treat their patients in this holistic type of way.
Karli, I love really everything you just said. Your energy is like infectious about this stuff, which makes it really fun to just to chat with you about it. And I want to use even your website, the Gaining Health website, has kind of some of that infectious energy, I would say. Your vision statement is that my vision is a world where all people will have access to science-based, compassionate obesity care. Together, we can transform healthcare to create a happier, healthier world, relieved of the burdens of chronic disease. And you kind of started to get into this a little bit, but I want to give you a chance, maybe even just to expand on it a little bit more. Can you share a little bit more about what that vision means to you, and how you would hope to achieve that in your career in the next several years, I guess?
Yeah, I think it all stems from what I saw happening with my patients when I started treating their obesity. So we didn't learn how to treat obesity in my PA program. At the time when I graduated, this was back in 2011, obesity wasn't even recognized as a disease yet by the American Medical Association. That didn't happen until 2013. So I never learned about obesity as a disease. I never learned how to treat obesity. All we really learned, if you will, was that it was just about calories in, calories out. And if somebody needed to lose weight, then you recommended, well, let's try eating less, eating better, moving more. And that was about the extent of the advice that we could really give people. And so when I started out my first job out of school, I was working in primary care. And it was also an integrative medicine practice, because that was really important to me, that it really was this, preventative approach. And so I would see my patients, who were developing hypertension, hyperlipidemia, diabetes, and I would really try to work with them on the lifestyle components. And we even had a health coach. So I could refer to the health coach who could help them with these things. But what I found was that it was so challenging for so many of my patients to lose weight and to keep that weight off long term. And I didn't understand at the time why it was so challenging for people. And my patients didn't understand why it was so challenging for them. They're like, I'm trying, I'm doing all these things. And I just, sometimes they would lose weight for about the first 6 months or so. And then gradually the weight would start coming back. And a lot of times I would just end up having to write prescriptions for these medical conditions, because, we had tried the lifestyle stuff and sometimes it would work to some degree, but especially people with more severe obesity, it was just really challenging. And it got to the point where it became kind of frustrating for me and for my patients. I'm sure they were frustrated too. And we ended up moving. So this was when I was in Arizona. I ended up moving to Texas. And when I moved there, I was like, I'm not sure I want to do primary care again. Because to me, I wasn't having the effect that I wanted to have on patients' lives. And I ended up finding a job in bariatric surgery. And so I thought, well, maybe in that situation, because they said, oh, we would love to have you, counsel our patients on the lifestyle components, because obviously with bariatric surgery, it's not just the surgery that works by itself, right? The lifestyle changes have to come along with it. And so I did a lot of counseling before and after surgery on the lifestyle changes. I did a lot of educating around the surgical procedure. I was in the OR myself too. And seeing the change that the surgery in combination with the lifestyle changes had on people's lives was incredible. Just seeing, people just had like a new lease on life. They just had a different glow about them when they were finally able to get the help that they needed to help them with their obesity. Finally, they were getting off of all these medications and they just felt so much better. And they were able to do all the things that previously maybe they couldn't do before. Maybe like flying was even a big thing for a lot of my patients. They weren't able to fly or fly comfortably, or they'd have to ask for a seatbelt extender, or just being able to walk along the beach without having to stop every few minutes, or get on the floor and play with their kids or their grandkids. So there was just so many ways that I saw their lives just transformed when we actually treated the obesity. And so at that time, this was, around 2014, 2013, 2014, they were also starting to come out with some of these new anti-obesity medications because finally obesity had been declared as a disease state by the American Medical Association. And so, there's a big jump between lifestyle changes and bariatric surgery. And so I wanted to know, what can I do as a PA? I feel like there's more that I should be able to do in between these two things. And so that's when I found out about the Obesity Medicine Association and this whole field of obesity medicine that I didn't even know existed prior to that. And so that's where I've really kind of found the sweet spot where I, as a clinician, feel like I can do so much for our patients. I can do the lifestyle counseling. I can give them medications if that's what they need. If they need a referral to bariatric surgery, I can do that. And I can talk to them about surgical treatments. Or if they've had surgery, we know that about 30 to 50% of patients who undergo bariatric surgery end up regaining a lot of that weight after the first few years. And it's not because it's not their fault. It's just the disease of obesity is coming back. And the surgery is a great tool, but tools get dull over time and the body compensates for some of the surgical changes that have happened. And so it just really stemmed from seeing the difference that you can make in somebody's life when you're helping them lose weight and manage their obesity successfully and the impact that that has on people. And so it got to the point where I'd started several of these obesity programs in different settings just because I've moved from state to state several times. And, there's just so few people that have access to that type of comprehensive evidence-based obesity care because there's not that many clinicians who have received that training. Because again, a lot of times you have to go outside of your medical training to receive this type of training in obesity care. And so I just wanted to do everything that I could possibly do to educate more providers about this field and then to help them start their obesity programs, just because if everybody had access to this type of care, I think, so many people would be much healthier and much happier, and we can really relieve this burden of chronic disease that so many people are living with day in and day out. And that's what drives me every day, because I think we can really make a huge difference in people's lives if we approach it that way.
I love your passion. I love your um change the world attitude because I can totally relate to that. The last guest was Sheila Waugh, and and we talked about lifestyle medicine, and as you know, we're well, and Thomas as well. We're involved with the American College of Lifestyle Medicine, um, and it does get that excitement going in you when you see the power of lifestyle medicine, and when you see the power. As I've told you before, my first job out of college was at Duke University Medical Center's Night and Fitness Center. It started as an internship. And I can literally remember, this is back in 1996, and I can literally remember my first week there as an intern. And since I was an intern, I roomed in the same basically building across the street that the patients had rooms in, and I ate in the same cafeteria. And I can just remember overhearing the conversations and their excitement of
Mhm.
really everything that you just touched on. And that's been fueling my fire now for almost 30 years as well. So there's so much that you just said that I can relate to, and it's exactly right. It makes you wish that everyone experienced this stuff, um, because then it does give you that I want to change the world mentality. And so you and I definitely have that in common. One quick question I had, I'm just curious about, is I personally have been like Duke was an example of a model that was truly integrative. They had medicine, behavioral, fitness, and nutrition components, and we had weekly team meetings, and we were truly integrative. And I'm not going to name names, but I've definitely been at other facilities where, in name, we were integrative, but in practice, it was a little bit too. It was
Siloed. Yeah.
exactly too siloed. So I'm just curious because you mentioned being in integrative model, and do you feel like you've had that the integration was truly integrative and that you've had good experiences there? I'm just curious about that.
I've worked at a lot of different programs and it's been very different at each program. And some of it just has to do with the staff that that program is able to support. So, I've worked at small programs where they just can't afford to have a dietitian and an exercise physiologist and a psychologist and the healthcare provider on staff. And then I've worked at programs where they've had all of that. And so I think it just depends on the program, the size of the program, the funding they have available, also their mission and their vision. So they have to believe in that, obviously, but it also has to be financially viable. So that's something that I talk about a lot when I'm helping people set up their practices is what is realistic for you. Look at your finances, because first and foremost, it has to be financially viable. Otherwise, you can create your dream program, but if you can't support it financially, then it's not going to be able to be successful and continue, and you won't be able to help the patient. So, as an obesity specialist, what's nice is that we do get trained in nutrition. We get trained in the physical activity and the exercise component. We get training in motivational interviewing and how to help with behavior change. So there have certainly been programs where I have kind of done all of that. I did the nutrition counseling, the exercise counseling. I was the kind of the behavioral specialist. And so because that's something that I enjoy doing, it worked out and it was great. But then other programs, it's really nice too when you have other people, when you have the dietitian that you can refer to, who obviously is going to have more in-depth training, right? And is going to be able to offer other tools or have other tools in their toolbox that I may not have. And so I love working with the team because everybody's going to come at it with their own unique approach and might be able to think of something a little bit differently or have a different skill set than what I might have. And so it's really nice to work together as a team if that's something that's feasible.
So, Karli, I loved how you went into your vision and just shared a little bit more background about where, where this all started for you. What I'll say, my experience as a physical therapist, I came out of PT school and I knew, I would say, next to nothing about obesity management or obesity as a disease, which is saying something. I came out of PT school in 2017, and even then at a school like Duke, we were getting the most cursory, very little information on what that looks like for guiding our patients on, on their journey with that condition. My experience was that I saw people who, pretty early on had gone through bariatric surgery and had amazing results, kind of like what you were talking about. And it blew me away that truly the only option for people was to have bariatric surgery, or the other side was kind of figure it out on your own, right? And I think you've teed yourself up really well to go into the next part of this, because anybody who's listening right now is probably wondering, how do you do this in between? How do we serve people in a way that's different, that isn't necessarily going the bariatric surgery route, though that is totally appropriate and a great option for some people. I think it starts a little bit with the OMA, which is outlined 4 pillars of clinical obesity treatment: nutrition, therapy, physical activity, behavior modification, and pharmacotherapy. So if you could, just starting with nutrition therapy, could you give us a little background about how you incorporate each of these into your practice, and maybe even how your approach to these pillars might be different compared to another physician or PA in primary care?
By the way, most people looking for the services of a fitness professional are really just looking for information on how to get started on the right path, not to pay for training sessions every week for months or years on end. For the 60 to 70% of people with chronic disease and or joint pain, they're also looking for someone who can help them develop a clinically safe, individualized exercise program that takes their conditions into consideration. If you're interested in getting yourself, or for clinicians, your patients, started on a safe, cost-friendly medical fitness program, you can find more information about the virtual services we offer at mrfinstitute.org/services. We staff only degreed kinesiologists and exercise physiologists, and will work with your healthcare providers in the design of your exercise program. For the clinicians listening in, you can add this virtual service as a reduced cost option for your patients. Check out our website and send us an email, and we'll give you the details about this unique and much needed service.
Yeah. Well, I think in terms of how it's different, like you said, most physicians or PAs or NPs, and as you said, physical therapists just haven't received any training around obesity, or very little training also in nutrition or physical activity counseling or things like that. So one thing is just having that additional education, I think makes a big difference. But the way that I approach it in practice, so I'll kind of give an example of, how we would treat a new patient, right? So a patient would come in and we schedule them for their initial assessment. And what I kind of tell them is, this is our chance to get to know each other, for me to understand your medical history better, to understand your weight history. And so we talk about that. We ask, is it okay if we discuss your weight history? And so that's the first thing we do, is we go through their medication list. This is one of the things that often contributes to obesity that people are not even aware of. And even a lot of prescribers are not aware that a lot of medications have the side effect of causing weight gain, right? So that's one of the first things we look at, is we go through their medication list to see, okay, are there any medications that you're on that could be contributing to your obesity? And then we also take that weight history. So starting, when they were young, or, when did they first start to struggle with their weight? Was there anything going on in their lives at that time? Because we do have patients who've experienced trauma or abuse, or, certain things that triggered their obesity early on in their life. Or sometimes it was when they had a medical diagnosis, or when they were started on a certain medication, and that's when they noticed that their weight started to change. So we're looking for all these little clues to understand somebody's weight history, because obesity is such a, it's such a diverse disease state, and there is no like one form of obesity, right? So everybody has their own little puzzle pieces, what I call them. And I say, we're just trying to take all these little puzzle pieces and put them together so that we can come up with a plan, an individualized plan that's going to work for you. Because what's going to work for you is not what's going to work for your neighbor or your sister or your coworker, right? So it's really important that we understand their medical history, their weight history, potentially, some of the factors that make it challenging for them to lose weight right now. And there might be financial barriers, or, anything like that. We want to understand what their day-to-day looks like. Who do they live with? Who are they taking care of? What do they do for their occupation? Do they work night shifts? All of those things are super important. So we start by taking a thorough assessment. And then that also includes assessing their nutrition and their physical activity and their sleep, and screening for all of those things. And then we'll order labs also. We'll do a physical exam, and we order labs at that first visit, because there may be medical conditions that could be contributing to their obesity. We know things like hypothyroidism. Obviously, we want to check the thyroid. It's fairly rare that that's what's causing it, but still we want to check that. Things like insulin resistance, a lot of people, so I check fasting insulin levels. Some people might know if they have diabetes or pre-diabetes, but they're not going to know about insulin resistance, because most healthcare providers don't check those types of labs. We want to make sure we're assessing their metabolic health. So doing a lipid panel and doing their hemoglobin A1C. So we're doing a thorough workup to really understand metabolically, what does their health look like? And because those things can also augment their treatment plan. So once we kind of do that thorough assessment, and we do a body composition analysis as well. So once we get a better picture of our patient and their health goals, and what types of nutrition plans perhaps have worked well for them in the past, and what hasn't. So we really want to take all of those things into consideration. And then based on all of that, we'll put together a plan for them. So we oftentimes will start with a nutrition plan, as you mentioned, because we see that when it comes to weight loss, we know that changes in nutrition are going to be probably the most important thing. So we usually start there, and then we also assess their appetite, because this is a big thing in obesity medicine. So we know that obesity is a medical condition where that energy regulation part of the brain, and that's the part of the brain that also controls appetite, so hunger and satiety, these are not things that we determine on our own. These are not conscious things that we determine whether we're hungry or not, right? Those are hormonally driven in your hypothalamus, which is not a conscious part of your brain that you have any control over, right? And so helping people manage their appetite is super important, because I think for so long we've just told people that it's about willpower, well, you just need to eat less and move more. Well, eating less, guess what? When you're in a calorie deficit, that makes you hungry, right? And then not only that, but also when we lose weight, so your body has a set point for whatever your weight is. And as soon as you start to lose weight, especially when you get to about 10% of that body weight loss, your brain starts to fight back because it sees weight loss as a threat to your existence. Because for the millions of years that humans have roamed this earth, gaining too much weight was not the concern, right? The concern was starvation. So the way that our bodies are designed, they're designed to protect us from weight loss. So when we start losing weight, your hormones like leptin, which is a hormone that's produced by your fat cells that tells your brain about your fat stores, that hormone starts to plummet. And that tells your brain that you're losing weight. And so in response to that, your brain will actually increase your hunger hormones and decrease all of your hormones that tell you that you're full to make you hungrier. And it will also reduce your metabolism, all to try to get you to regain the weight. And so this is the type of science and physiology that most people are not aware of. And so when somebody loses weight and then they regain all their weight, the person blames themselves. Society tells them they're just not trying hard enough, when really there's a lot of biology and physiology that's driving that weight regain. So we have these types of discussions with our patients. We assess their appetite. We see how they're feeling on their nutrition plan. And if they're struggling, if they're like, I'm really hungry all the time, or I'm having cravings, then we talk about potentially adding pharmacotherapy as an adjunct to the lifestyle changes that they're making so that they're better able to stick to their nutrition plan long-term. Right. So, and then we'll follow up with them on a regular basis. Usually, initially, I might see my patients every 2 to 3 weeks. If they're on insulin or other medications that really need to be monitored more closely, sometimes I'll even see them weekly. And then as they kind of get settled into their plan, usually we see them monthly or every other month. And we just continue to adjust, continue to adapt, perhaps medications, adapt their nutrition plan. We start including physical activity. That's when we really start to talk about a lot of that and making sure that as they're losing weight, they're losing the right kind of weight. They're losing fat mass, not muscle mass. So that's where the resistance training really comes in. And so, all of these behaviors are so complex and there's so much to talk about that even these monthly visits, there's always little tweaks that we can make and little goals that we can set to help the patient ultimately achieve the health goal that they are looking for. And I always tell people it's not about reaching a magical BMI or some ideal body weight. It's about being the healthiest version of you and the patient feeling good and having the energy and the ability to do all of the things that they want to do in their life without being hindered, by their weight or other medical conditions. And so I don't really care what their weight is. If they are feeling good and their labs look good and they can do everything they want to do, that's the ultimate goal.
So Karli, what I heard you say to start that was that you do a really thorough evaluation, really to address obesity as a condition. And that's so different than what you may expect to see in other places where provider may kind of beat around the bush or not go directly towards the conversation of obesity, or maybe they do and mention it briefly and that's kind of it. What does doing that direct approach do for you as a provider and for your clients in comparison to what, maybe the beating around the bush or not going directly at it? What does that do for you and your patients?
Yeah, I think people really appreciate when you talk to them about obesity, straight on as a medical condition. And I know it's difficult for providers and also sometimes for patients to bring up the topic of weight because it is a sensitive topic. There's so much weight bias and stigma, unfortunately, still out there. And so it's a tough topic to broach for a lot of clinicians. Now, I'm an obesity specialist, so people are coming to me. They know that they're going to be talking about their weight. But I know, and I can respect that for somebody working in primary care or in another specialty where maybe that's not what the patient came in for that day, that it can be difficult to bring it up. So what we recommend is that you start with just asking permission, right? So that's a respectful way. You're including the patient in the conversation. So simply bringing up, I'm seeing your weight, your BMI, I'm a little bit concerned. Would it be okay if we talked about your weight and how it might be affecting your health? And then, you can see what the patient says. And actually the vast majority of patients, and this is shown from the ACTION study and other studies that have looked at this, the vast amount of patients are actually very relieved that the provider brings it up, because it's something that they know they're struggling with it for the most part. And they've been struggling. This is often for many years. And they have always felt like this is something that they should figure out on their own, right? That this is not something that you talk to your medical provider about, because I should be able to manage my weight on my own. It's so simple. It's calories in, calories out. Why can't I figure this out, right? And so that's a lot of that internalized weight bias, where people blame themselves for their condition. Well, I did this to myself and I just must not have self-control. So, a lot of patients actually are relieved when their clinician brings it up with them. And then I think just having that direct, frank discussion and explaining a little bit about the pathophysiology of obesity, that it's not for a lack of willpower. It's not that they're trying hard enough. It's just that everybody's different. Everybody's genetics are different. And that some people are genetically much more prone to developing obesity than other people. And we currently live in this obesogenic environment where if you have those genes that promote weight gain in the type of environment that we live in, you probably are going to develop obesity, right? That's why over 70% of the population has pre-obesity or obesity at this point. Over 42% have full-blown obesity. And it's because, we've had all these changes in our environment, especially over the last 100 years. But, our genes haven't changed, and our genes are still such that, a lot of people have genes that make it very easy for them to gain weight, which again was protective for many, many years. That's what allowed you to survive periods of famine. But now these genes, kind of work against us in this current environment that we have. So I think just explaining some of that really helps people lift some of that, the shame that they feel around their weight. And then once they understand, okay, so this isn't all my fault. And on top of that, yeah, we do have like evidence-based safe strategies to help you overcome some of these challenges, right? Because sometimes it feels like all gloom and doom. Like, yes, these are your genetics and this is the environment that we live in. And then when you start to lose weight, your body actually fights against you and promotes you to regain that weight. Sometimes it can kind of feel like, well, this is a losing battle, right? And so I think it's important for them to recognize that, yeah, there's some of these factors that might be working against you, but there's hope. We have these treatment options. We have these things that really work, that are safe, and we're here to guide you every step of the way. We're here to make sure that it's safe and effective, and we're here to support you. We know this is not easy, and it's a marathon, not a sprint, but we're here to support you. And I think people really appreciate that.
When I listen to this and being a non-clinician, some of the things that go on in my head, and Thomas has heard me say this before because I say this to him often, is that having worked in 4 hospital settings and 3 private practice settings, I found that people like you and Thomas and Sheila are outliers. And I know that, part of your response was that as an obesity specialist, there's kind of an expectation from the patient side that you will talk with them about that. And I'm sure that's true. But I've just found that there's a lot of clinicians that do tiptoe and don't want to ask these tough questions and stuff like that. So, you know, I don't know if I really have a question for you. I just want to kind of interject that because I see you as different, and I see Thomas as different, and I see Sheila and a few of the other clinicians that I'm very fortunate to collaborate with as different. And I wish that everyone had this. It just makes me wonder, what? Yes, part of it is that you're obesity medicine specialist, and so there's an expectation. But part of it is there's something different. There's something different about you and Thomas and the others, whether it's your confidence or and I don't know what it is, but I love hearing this stuff because of the fact that I've worked in these settings where this is not the case. And it's very frustrating for me.
Yeah.
So I don't know if that's leading to a question or a response from you, but that's partially what I got out of listening to what you just said.
Yeah. And I think you're right. And I think for a while I was like, well, maybe it's just there's something different about me. But what I'm finding is there's so many clinicians who are dying to hear this information. We're seeing the growth of the field of obesity medicine. It is the fastest growing medical field right now. There are so many physicians who are now becoming board certified by the American Board of Obesity Medicine. I mean, that's skyrocketing. And there's so many NPs and PAs who just they learn about this field. Again, many of them have never heard about it, but it's starting to get out there more, especially in the last year. People are hearing more about this, and they're so thirsty for this knowledge. They really want to be able to help their patients, because I think a lot of clinicians become frustrated and burned out too, right? They just see their patients and they just see them getting sicker and sicker, and they're just adding more and more medications. And that's tough on providers as well, because the reason why we went into the medical field is because we want to help people, right? Most of us, that's why we went into this field. And it's just frustrating when you feel like you really can't help your patients and you're just kind of putting band-aids on this, and then they're just back next month with something else, and you're just having to add more and more medications. And meanwhile, your patient is just feeling worse and worse because all these medications, add up and start to make patients feel worse. A lot of medications have side effects. So I think a lot of clinicians really do want to do better by their patients, and they want to learn this type of science, and they want to help their patients in this way. And so I think that's what's really motivating to me is I see more and more clinicians, and especially a lot of the younger people that are just graduating medical school and PA school and NP school. They really are so interested and fascinated by this field. And I feel like it's finally getting some legitimacy. For a long time, when I first started in this field and I told somebody I was an obesity specialist, like people would kind of look at me like, what? Or, you help people lose weight. So like, almost like you opted out of medicine, like, oh, that's some kind of fringe, or like, is that like a med spa, like medical weight loss? And I'm like, no, it's not like that. This is a true medical specialty. And so it's cool to see that the field is evolving, and I'm hopeful. And just from what I see from other clinicians, that people are so interested to learn more about this field. And I think part of the confidence that you see is, I've been doing this for a long time. And so and I've had so much education around this that I feel confident that what I'm doing is evidence-based and that I know what I'm talking about. And when people are new to the field, they don't quite know yet, right? And so they might not have the same confidence, but it's like I said, it's exciting to see this field grow and just to see so many clinicians who want to learn more about it and really help their patients in this way.
So, as the Medical Fitness Podcast, it may not surprise you that we are particularly interested in the pillar of physical activity for people with obesity. What do you recommend in terms of physical activity for your patients, Karli?
Yeah, so as you guys know, it really depends on the patient, right? So it starts with kind of doing a thorough physical activity assessment to understand, what are they currently doing in terms of physical activity? What are their limitations? What have they done in the past that they've enjoyed? What are some of their barriers right now to being active if they're not active? Because I see some of my patients, they might even have severe obesity and they're working out 6-7 days a week for an hour, so certainly not the case that everybody with obesity is not physically active. A lot of people are, and despite that, they're still not able to lose the weight. So I think it just starts with assessing where they are, and then building from there. Like I said, some people they're doing great with that, and we can talk about other things, and we just want to make sure that they're also getting doing their resistance training and stretching and doing some of those other factors. So those people who are already very active, I know they're kind of good on that side, but we also have a lot of patients who are not active or who have chronic medical conditions or joint pain or other limitations that make it very difficult for them to be active. And so kind of depending on where the patient is and what their limitations are, that's kind of where we'll start. I do love referring to like physical therapy or referrals like that if people do have physical limitations, because I think a lot of people that have a lot of physical limitations, especially if they have severe obesity, they're scared to be active and to exercise because they're afraid that they're going to injure themselves, or that they're going to maybe injure another joint, or they're not sure what they're doing and they don't want to make mistakes. They also may not feel comfortable going into a gym because they feel like people are looking at them like, what are you doing here? And they're judging them because of their size. And so I think, physical therapy referrals is one of my favorite things, especially for people that have significant limitations and haven't been active. If they have access to a pool, especially if it's a pool in association with physical therapy, like a therapy pool, that's great, especially for our patients with severe obesity, because it just takes that weight off of their joints and they're able to be active in the water. So that can be great. Or even doing, some seated exercises if they're not able to, stand much or walk much, and just kind of start there. And I try to really focus also on the enjoyment of it and really getting it into a regular pattern into their day. So, even if it's starting with, 5 minutes once a week, if that's where we're starting, then that's where we're starting. And what can you do to make it more enjoyable? So can you listen to music? Can you do your activity with a friend, or, find an activity that you enjoy? So that it's always important to me that patients don't think of physical activity as like a punishment. You're not punishing yourself. This is a reward that you're giving your body. Our bodies actually enjoy movement. We feel better when we move. For some people, if it is causing pain, let's find something that doesn't cause you pain. And then we just gradually build on it, And so using resources, if we have trainers that we know are well educated. And I think it's really important that whenever we do refer to people, that we know that they know how to work with our population, because unfortunately, again, we see it everywhere. There's so much weight bias and stigma, and we see it amongst, nutrition specialists and dietitians. We see it amongst healthcare providers. We see it amongst exercise specialists as well. And so the last thing you want to do is refer your patient somewhere where they're not going to be treated well, or where they're going to be judged for their size or dismissed because of their size. So I think that's an important thing, is making sure that whoever we're working with, we feel comfortable with, that they know how to take care of our patients, and that it's a positive experience for our patients. And then again, just individualizing it. Each person is different, and we just gradually build on their physical activity from one visit to the next.
I will interject and say that I wish I could take the whole fitness field, or nearly the whole fitness field, and shake it, because what you just said is just so frustrating to me. And I have my degree in kinesiology, but 10 years into my career, and I start working in, I had the Duke Medical Center thing, but that was, for the first year, and I was green and all that stuff. But then flash forward 10 years into my career, and now I'm working in a Mount Sinai Beth Israel facility here in New York City. And it was exposed in me that I was the one that you didn't want to send your patients to. So I know what it's like to be on that side of the fence. And it was such a humbling experience to be like, oh my God, I'm 10 years of my career, and their expectations, the standards way higher here in the clinical world. And I'm not meeting their standards. And I learned, and they were professional about it. So
Mhm.
this is not a complaint. It was me realizing literally within weeks, wow, this is a different world, and I'm not meeting these standards. And now, flash forward, almost 20 years, well, 17 years later, and I can clearly see that most of the fitness field doesn't meet the standards. And so if I can understand the frustration and the justifiable frustration from the clinician standpoint, and that's the reason why I get questions all the time. How do we vet? What do we look for? How do we find the people? Because it's exactly right. The theme that has just presented itself over and over and over again from my end, starting with the initial consultation, is apprehension, being scared,
Yeah.
and all those related words and phrases that, they don't want to get hurt, and they want to know that someone like me is going to uh, has the skill set to be able to design safe programs for them. So I really can understand where you're coming from, more than you know. And I don't know how frustrated you are, and I'm not going to ask you that loaded question, but I'll let you know that I'm very frustrated with the fitness world. I just think the standards just need to be way higher to work with, not only with those living with obesity, but also just generally speaking, the musculoskeletal world, the rehab, post rehab, other chronic conditions as well. So
Yeah.
just want
And
to,
I mean, thank you for your honesty. And I will say, I mean, I was the same way before I learned about obesity as a disease and all these hormones and stuff. Like, I was also like, okay, well, people just need to eat better and they just need to move more. So I, again, was part of that. I stigmatize patients as well, And so I think, but when we know better, we need to do better, right? And so once you learn, once you understand, then we do better. And like what you're doing right now, you're passing that on. You're passing your knowledge on. And that's the best that we can do, right? When we learn, then we know better and we do better. But, you know, healthcare providers are the number one or number two source of weight bias and stigma behind family members when it comes to obesity. So, you know, we have a lot of work to do in our field as well.
While Jeff, I think, is discouraged on the fitness side, I think what I'll even say is that I think both of us probably feel seen a little bit right now too on the other side of it, where one, I want to call out, you correctly identified physical therapists as addressing physical limitations rather than being people that just fix pain, which I really appreciate. That's where I feel seen the most. But I think Jeff and I both, you know, we talk often about having this pathway from medicine to rehab to fitness. And, you know, for you, Karli, if your comfort zone is let's get him, there's some kind of physical limitation that my patient is dealing with right now, let's get him to start in physical therapy. Let's get him to start somewhere. And if your PT is working with a fitness professional, and, you know, I used to get referrals all the time for, and I say used to because I'm not in practice anymore, not because these referrals aren't coming into our system, but that I would get referrals for obesity as a diagnosis, for high blood pressure, hypertension, and high cholesterol as diagnoses, and not necessarily a orthopedic condition like a lot of PTs were used to seeing. And part of that is that, you know, my clinic said lifestyle medicine on the wall. But I had to get used to identifying, okay, this person isn't coming in with like, you know, XYZ orthopedic condition. How do I help them with their physical limitations? And there's so much that we can do with those people, which includes also helping just get them started with exercise. Because a lot of the time, the momentum that I can start to build rolls right into what Jeff and the fitness professionals can do, and start that experience of, I think I can, I believe I can, and now I'm going to do it. So again, I just want to say I feel seen right now. I appreciate you calling out PT as being those physical limitation people, because it's exactly how I think we should be seen.
Yeah. And I love that there's that progression, right? Because at some point, you know, the physical therapy visits do run out, or, you know, people can go beyond that. And so that's when it's really nice to have an exercise physiologist or another specialist who can then take that over. And yeah, we're all working as a team with the same goal of getting the patient feeling as good as they can and helping them be their healthiest version of themselves. And patients are so grateful when they receive that kind of help and they can see the progress that they're making. And, you know, I had one patient who went from not being active at all, and she was in her mid 60s, and, you know, she was just kind of this timid lady who had always taken care of everybody else but herself. And I was talking to her about physical activity, and she was like, well, I mean, I guess I could go to the gym after work, but like, that's my husband's time for me and my husband. And I was like, well, let's see, where's your time? Because you're taking care of other people all day. And then you say that's your husband's time. Where's your time? So she decided to carve out some time for herself. And then like a year later, she was doing CrossFit competitions in the senior league. So like, it was just so cool. And she just felt so good, and she felt strong and confident. And it was really amazing to see the transformation. So it's really great when you can see that type of transformation and what it's doing for people.
Yeah, absolutely. I'd love to ask you, because I think it's an important question to ask in this kind of conversation, but what are some common misconceptions around obesity or obesity care that you'd like to highlight?
Yeah, I mean, I think some of the things that we talked about already, just the weight bias and stigma, that it's just a matter of willpower, people not understanding the complex physiology that causes obesity and that's involved in obesity, not understanding the appetite regulatory system in the brain and how that can actually go awry. There's all these hormones that get released. There's hormones like ghrelin that get released by our stomach that make us hungry. And then there's all this whole slew of hormones that gets released when we eat that tells us when to stop eating, right? And so one of these hormones, just as an example, is GLP-1. It's produced in the small intestines. And studies have shown people with prediabetes, people with diabetes, people with obesity don't make enough of this hormone, right? Or this hormone's not working correctly. And so that's why we have some of these new medications that I'm sure you've heard about because they're all over social media, but, you know, medications like Ozempic and Wegovy, these are GLP-1 medications. And so what it does is it gives people more of that hormone. And then that hormone tells the brain that you've had enough to eat. It also helps control blood sugar because it also talks to the pancreas and causes insulin release. So this hormone has an effect on multiple different parts of the body. And so when we give people this hormone, more of this hormone for the people that aren't producing enough, hey, now all of a sudden they can stop eating at an appropriate time, what would be considered appropriate, right? So they're eating an appropriate amount of food. Their blood sugar is better controlled. So I think the more we understand about the hormones and the physiology that's involved in obesity and the things that go wrong, right? Once we understand kind of what's broken, then we know better how to help people fix it. And so I think, the misconception is primarily that it's about, people just not trying hard enough, not having the willpower, when in fact, there's a lot more to it than that. I think that's the most common misconception. And I think that's what drives a lot of the weight bias and stigma too. And then there's that internalized weight bias where they've heard from the media, from their doctors, from their family members that it's their fault and that they should be able to fix this. So then people really do start to believe that about themselves, that, well, I did this to myself and I should be able to take care of this on my own. And I must not have any willpower. And that's really damaging when people start to believe that about themselves. And so sometimes it's a lifetime of that kind of self-talk. So that can be challenging to change, but little by little, it's amazing when we do get through to our patients.
Yeah. So just physiologically, obesity is more complicated than you're not trying hard enough, and that the shame cycle really just isn't helping anyone.
No, exactly.
Well, Karli, I'm a huge fan. I want to know how I can learn more about you and the things that you're doing. Do you mind just sharing how we can stay connected and follow you as you move forward?
Yeah, sure. So our website is gaininghealth.com. So you can learn a lot about just gaining health, what we do, the kind of products and services that we have on our website, gaininghealth.com. And then, people can always follow me on LinkedIn. We also have a Facebook group called My Gaining Health on Facebook that's specifically for gaining health, but it's not a private group. It's open to anybody. And then the podcast. So it's the Gaining Health podcast. And so I talk to a lot of the other leaders in obesity medicine on that podcast. And I also give updates on, when there's new research that comes out or, new guidelines that come out. I share all of that information as well, because I feel like the more I can do to let people know about evidence-based and compassionate obesity care, the better. So I've been trying to scream it from the mountains for as long as I have known about obesity medicine. So I'll continue to do that.
This has been great, Karli. Thanks so much. It's been informative. Love your passion. Absolutely love it. Thanks so much for the time and being a guest on our show. I really appreciate it.
Well, thank you guys so much for having me.
Do you need assistance in connecting with a fitness professional in your local area or virtually to add this connection to your patient services? If so, please email mrfinstitute.org@gmail.com. Please also remember to check out mrfinstitute.org for information on how to learn more about the education we offer and to stay current with our podcast series. Thanks for tuning in, and we'll see you in the next episode.